Thank you, Dr. Goodsman, and it's a pleasure to be here, and thank you to SCAI. Great to see all the new fellows of this great organization. I'm going to be just giving you my particular view of what's happening in 2017 with CTO PCI. And the word that I would like to use is we're now integrating CTO PCI into complex PCI. So this is the idea about chip, and this is simple intervention, and then there's a whole array of new techniques, so multi-vessel disease, left main stem disease, rotablation, using left ventricular support, which I'm going to talk more about, but really the driving technology, the driving techniques now that are at the top of this pyramid are CTO PCI. So CTO and the techniques that we have in 2017 are driving the expansion of chip PCI and complex PCI more generally. Now, CTOs are important. We have done very badly in the past with the management of CTOs. Here you can see, this is from the first syntax study, a very low rate of revascularization. I'm not sure if that projects very well, but less than 50% of patients in this very key landmark study with CTOs were successfully revascularized. Now in 2017, this is simply not good enough. And the problem that generates is that patients are incompletely revascularized. So in 2017, what we need to be thinking about is not just opening the CTO, but opening the CTO as part of complete revascularization. The strongest predictor of incomplete revascularization remains a chronic total occlusion. Now, CTOs need to be integrated now into more complex patients. We are entering an age now where patients are being treated with CTOs but also with multi-vessel disease, often with poor left ventricular function, and we've got this concept now of protected angioplasty, so patients with complex coronaries, with hemodynamic compromise, with patient comorbidities. This idea that we need to protect patients whilst they're undergoing intervention. And in fact, this is from our own guidelines, where we've got that chronic total occlusion is something that is an important anatomical subset in patients being treated with impellers. Impellers, I think we're seeing increasingly used now. Now, this is the type of chronic total occlusion that we're now taking on. This is an occluded right, an occluded left main stem, last remaining vessel, and we've got this graft to the LAD, filling the circumflex, cross-filling the right. This is a high-risk intervention, but this is a CTO intervention. Now, sometimes if we take these types of case on, I decided to try and open up the left main stem. The aorta was calcified, so I didn't put a support device in. And as soon as I put a catheter into the graft here, in fact, what happened is the patient crashed. So I did carry out a form of protected PCI using CPR, in fact, and this is the recovery of the retrograde conduit, and then I was able to proceed on using the idea of protection. This is what happens when I engage the conduit, is that I lost the pressure. But in fact, what I'm able to do is we then put in a protection device. That was a carotid protection device. This is the retrograde conduit. And in fact, what we've done in this case is use one of the more modern techniques, which is antegrade dissection reentry, which we'll hear a bit more about. But in this very complex patient, we were able to integrate this very difficult technique. It takes a little bit of training, this one, but here we've used the stingray reentry, and we've managed to reconstruct this gentleman's right, and then we can go on more safely to do the left-sided disease. So in this case, what we've done is we've introduced some support, and we can keep the patient going. So this is where CTO PCI has reached. We've reached this stage where we can treat very complex patients with very complex disease safely. And the reason for doing that is to achieve complete revascularization. Now, we're looking at this idea now of surgical ineligibility. There are a lot of patients we're treating with CTOs who have either gone through surgery or are ineligible for surgery. So what we've now reached is this point of CTO PCI being used in patients who are extremely sick. This is a patient who has presented with left mainstem occlusion, with a blocked right, extremely sick, presented in extremis, with a poor ejection fraction. We've managed to rescue the left main. There's still the circumflexus hanging on. The right coronary artery is occluded. So quite a lot of work to do. This patient doesn't have a surgical option, and what we're able to do using advanced CTO techniques, so retrograde, here we've got a long segment of knuckling has been done, so retrogradely we can do reverse cart, and we can achieve this very quickly because we understand how to work with vessels very quickly in this hemodynamically compromised environment. So we can open up the right coronary artery, we can then treat the left mainstem. So the message here is we can treat the CTOs, but we can also treat the CTOs as well as the other lesions for complete revascularization. And that's really where we should be heading. I'll give you another rather extreme example of a patient with CTOs who's got severe aortic stenosis, poor left ventricular function, osteal left mainstem disease, multivessel disease, blocked LAD, blocked right, severe peripheral vascular disease. In fact, this is a patient who almost everybody would turn down. Probably the best route for this patient may have been palliative care, but he's 60 years old. So high-risk surgery, well, the surgeons in our case turned him down. But we now, with techniques in 2017, with complex PCI and CTO techniques, can achieve complete revascularization, or at least near complete revascularization. So in this case, we thought about undertaking protected CTO PCI with an impeller. We used a transcaval approach. So we are using so this is snaring a wire from the aorta through into the vena cava. So vena cava into the aorta. We pull the wire through. So this is enabling us to bypass the disease in the femoral arteries. And in fact, what we're able to do is then pass a large caliber sheath. So this is a 22 French sheath going from the aorta so from the femoral vein into the aorta. We put the sheath in. We can put through this our impeller device. We can put the impeller in. We can begin to start to reconstruct these coronary arteries. So lots of wires in. There's an LAD CTO. There's left mainstem rotablation. Lots of stents going in here. Reconstruction of the coronaries. Fairly satisfactory result. There's some territories we didn't do the right in this case. And then at the end, we can just fix the aortic valve. This is done very quickly, a Sapiens 3 TAVI. So this is really where complex PCI techniques, CTO PCI, has reached in 2017. We see the integration of all these techniques with the aim of achieving complete revascularization. In this case, this patient has had a rather extreme intervention, but fortunately is well and has left hospital. We actually closed off the hole in the aorta using duct closure. So this is one of the new techniques that we're using to bypass people with severe peripheral vascular disease. So that's just a really taster of the type of work that we can now do, with all these new devices. So advanced CTO PCI techniques drive the expansion of complex techniques and increase the rates of complete revascularization. We have seen direct evidence of that in the Syntax 2 study. Now, I haven't got those slides to present for you, but this is an important study which has really updated the success rate of this from the Syntax 1, going from, if you remember at the beginning, 50%, less than 50% of chronic total occlusions were opened in Syntax 1. In 2017, it's 90%. And what that's doing is it's driving complete revascularization. There are two key technologies. There's the CTO PCI and the LV support, which are driving this move towards complete revascularization. And it's complete revascularization that should be the aim for all CTO and complex PCI procedures. Thank you very much.